Enzymes are biologic catalysts. A holoenzyme is made up of a protein portion, called the apoprotein, plus a possible cofactor. The measurement of enzyme reactions can be influenced by several factors. These include the concentration of reactants, the pH level, since each enzyme has its own optimal pH, the temperature, with most enzymes working best at 37 degrees Celsius, and the rate approximately doubling for every increase of 10 degrees. Enzyme activity is also affected by ionic strength, as well as the presence of cofactors and coenzymes. There are different types of enzyme inhibition. A competitive inhibitor binds directly at the active site of the free enzyme. A noncompetitive inhibitor binds at a site other than the active site, changing how the enzyme works. An uncompetitive inhibitor binds only to the enzyme's substrate complex. These inhibition types can be studied using a Lineweaver-Burk plot, which graphs 1 over substrate concentration against 1 over velocity. When it comes to measurement, we use zero-order kinetics. This means there is a large excess of substrate, so the enzyme itself becomes the rate-limiting factor. Enzyme activity is measured in international units. 1 international unit represents the amount of enzyme that catalyzes the utilization of 1 micromole of substrate per minute. What we determine is the catalytic activity rate, not the actual mass or concentration of enzyme. Timed measurements are important because they help avoid problems such as lag phase, substrate depletion, or product inhibition. When we look at enzyme activity over time, the curve has several important phases. At the very beginning, there is what we call the lag phase. This is a short delay before measurable product formation is detected. Following the lag phase, the reaction moves into its initial slope. This slope represents the true rate of the enzyme reaction under ideal conditions, before any limiting factors set in. As the reaction continues, it may shift into a first-order reaction phase, where the rate depends directly on the amount of enzyme present. We then see the post-lag slope, which represents the true enzymatic activity after the system stabilizes. Eventually, the curve begins to flatten. This decrease is caused by either substrate depletion, meaning there is less starting material for the enzyme to act upon, or by product inhibition, where the accumulation of products interferes with further reaction. In summary, enzyme reaction progress curves help us identify the true activity of an enzyme by analyzing the initial and post-lag slopes, while accounting for lag phases and inhibitory effects. Creatine kinase, or CK, is elevated in cases of muscle damage, cardiac damage, or brain injury. Reference ranges tend to be higher in males because of greater muscle mass and higher physical activity levels. CK exists in different molecular forms called isoenzymes. It has 2 subunits, M and B. CK1, also called CKBB, is made of 2 B chains and is found in the brain, gastrointestinal tract, colon, prostate, and uterus. CK2, or CKMB, is made of 1 M chain and 1 B chain and is found in cardiac muscle along with CKMM. CK3, or CKMM, is composed of 2 M chains and is the predominant form in skeletal muscle. When skeletal muscle undergoes trauma, total CK increases, and the CKMB isoenzyme also rises. However, the percent of CKMB activity is typically less than 3% in trauma. By contrast, if the CKMB fraction rises above 6%, it is strongly indicative of a myocardial infarction or heart attack. As for lactate dehydrogenase, or LD, levels increase in several conditions, including myocardial infarction, liver disease, muscle trauma, renal infarct, hemolytic diseases, and pernicious anemia. Some laboratory errors can affect LD measurements. Hemolyzed specimens can falsely elevate LD, and prolonged contact of serum with cells may also distort results. LD is usually measured using a spectrophotometric method. The enzyme catalyzes the conversion of pyruvate to lactate, while simultaneously oxidizing NADH to NAD. The rate of decrease in absorbance of NADH at 340 nanometers is directly proportional to LD activity. LD also has isoenzymes, formed from two types of chains, M and H. With 4 subunits, LD can exist in 5 different tissue-specific forms. These isoenzymes are separated and identified by electrophoresis, which helps pinpoint the source of disease. Next is aspartate transaminase, or AST. This enzyme is found in cardiac muscle, the liver, red blood cells, and several other tissues. Its levels rise in conditions such as myocardial infarction, liver disease including hepatocellular damage, cirrhosis, and carcinoma, as well as in muscle trauma, renal infarction, and hemolysis. Next is alanine transaminase, or ALT. Like AST, ALT rises in cases of liver disease, such as hepatocellular damage, cirrhosis, and carcinoma. However, ALT is more specific to the liver than AST, making it especially valuable for assessing liver conditions. Next is gamma-glutamyl transferase, or GGT. GGT levels rise in liver disease, with the highest increases seen in biliary obstruction and cirrhosis. It is also commonly elevated following alcohol intake. The measurement is done spectrophotometrically by detecting nitroaniline released when GGT acts on its substrate, gamma-glutamyl p-nitroanilide. Next is alkaline phosphatase, or ALP. This enzyme functions best at a pH of 10 and requires magnesium for activation. ALP is found in bone, intestinal mucosa, renal tubule cells, the liver's biliary tree, leukocytes, the placenta, and even in some tumors. ALP exists in different isoenzymes. The Regan isoenzyme is rare and the most heat-stable, classified as a carcinoplacental type. The placental form is also highly heat-stable. The intestinal isoenzyme is inhibited by L-phenylalanine. The liver isoenzyme is present in the highest concentrations, while the bone isoenzyme is the most heat-labile. Clinically, ALP is increased in several conditions. These include bone disorders with high osteoblastic activity, such as Paget's disease, osteoblastic tumors, rickets, and hyperparathyroidism. It is also elevated in growing children due to rapid skeletal growth, in disorders of the hepatic biliary tree such as obstructive jaundice, and during the 3rd trimester of pregnancy, due to placental production. Finally, let's review methods of ALP measurement. Spectrophotometric analysis is commonly used, in which ALP converts p-nitrophenyl phosphate into phosphate and p-nitrophenolate, which is then measured at 404 to 410 nanometers. Immunoassays may also be used for detecting the bone isoenzyme specifically. Let's continue with 5' nucleotidase, or 5-NT. This enzyme is increased in liver disease but not in bone disease. When alkaline phosphatase is elevated but 5-NT is normal, that points to a bone disorder. However, if both alkaline phosphatase and 5-NT are elevated, it indicates liver disease. Next, we have amylase. Amylase is produced in both the salivary glands and the pancreas. It requires calcium and chloride ions to function properly, so elevated samples should be diluted with saline rather than water. Amylase is unique because it is one of the only common enzymes that is normally excreted in the urine. The highest elevations of amylase are seen in pancreatitis and in obstruction of the pancreatic ducts, such as with malignancy. Smaller increases are seen in salivary gland obstruction, such as in mumps. Amylase can be measured by several methods. The amyloclastic method measures disappearance of starch. The saccharogenic method measures the production of glucose or maltose, and the chromolytic method measures dye release. In pancreatitis, urinary amylase stays elevated longer than serum levels. Opiates, like morphine, can also raise amylase levels. A condition called macroamylasemia occurs when amylase binds to immunoglobulins, resulting in high serum amylase but low urinary amylase. Importantly, this condition is usually asymptomatic. Now let's move to lipase. Lipase is also increased in pancreatitis, and in fact, It is more specific for acute pancreatitis than amylase. Lipase also remains elevated for a longer time compared to amylase. It is measured using turbidimetric methods, while older methods used olive oil substrates to track fatty acid production. The next enzyme is acid phosphatase, or ACP. Its primary source is the prostate, but it is also found in red blood cells, bone, liver, spleen, kidneys, and platelets. Clinically, the highest ACP elevations are seen in metastasizing carcinoma of the prostate, although nowadays PSA is more commonly used. ACP can also be increased in bone diseases, cancers that spread to bone, and in metastatic breast cancer. The tartrate-resistant portion of ACP is elevated in hairy cell leukemia. ACP also has forensic importance because its presence in seminal fluid can be used in rape investigations alongside PSA testing. ACP is measured by immunoassay for prostatic ACP or spectrophotometric methods for total and prostatic ACP. Tartrate buffer helps distinguish prostatic ACP from red blood cell ACP, since the prostatic form is inhibited by tartrate. For specimen handling, hemolysis should be avoided because it can cause false elevations, and samples must be refrigerated or frozen quickly to preserve enzyme activity. The next enzyme is cholinesterase. There are two main forms: erythrocyte acetylcholinesterase and plasma pseudocholinesterase. The role of this enzyme is to destroy acetylcholine after nerve impulse transmission. Unlike most enzymes, a severe decrease in cholinesterase is clinically significant and can cause serious neuromuscular effects. Decreased levels can occur in cases of organophosphate poisoning or in patients who have genetic susceptibility to certain anesthetic agents. Myoglobin is produced by muscles, including the heart. Levels rise in cases of muscle damage, including acute myocardial infarction, and also in renal damage. Myoglobin increases as early as 30 minutes after a heart attack, peaks within 4 to 10 hours, and returns to normal within 24 hours. If myoglobin is absent, a heart attack can be ruled out. However, if elevated, it does not confirm a heart attack because other muscle injuries can also raise myoglobin levels. CKMB, also known as CK2, is measured with immunoassays, which detect the concentration rather than the activity of the enzyme. It rises within 6 to 10 hours after a heart attack, peaks at about 24 hours, and returns to normal within 2 to 3 days. Although it was once the standard marker, CKMB has largely been replaced by troponin for diagnosis. Troponin is considered the single best test for diagnosing a heart attack. It is a complex of 3 muscle proteins: troponin T, troponin I, and troponin C. The cardiac-specific forms are troponin T and troponin I, and either one can be used for detection. Troponin rises about 4 to 8 hours after a heart attack, peaks around 12 to 14 hours, and stays elevated for up to 10 days. High-sensitivity troponin assays can detect very small changes, often using the 99th percentile as a cutoff. Troponin is also valuable for risk assessment and detecting reinfarction. BNP and NT-proBNP biomarkers are used to assess congestive heart failure. The levels of BNP and NT-proBNP correlate with the severity of the disease. They are released from the ventricular walls in response to high blood pressure and fluid overload. BNP promotes sodium and water excretion and causes blood vessels to dilate, lowering blood pressure. NT-proBNP, the inactive form, is cleared by the kidneys and may be influenced by renal function. When BNP is given as a medication, NT-proBNP is used to monitor the patient's natural BNP production. Both markers are also used for risk stratification. Other risk assessment markers include the high-sensitivity C-reactive protein, or HSCRP, a marker of chronic inflammation. It must be measured when there are no other inflammatory conditions present, such as infection or arthritis. Elevated HSCRP suggests increased cardiovascular risk. Homocysteine, an amino acid linked to vitamins B6, B12, and folate, can also be elevated and is considered a potential cardiovascular risk factor. Let's review the liver markers. The first enzyme is AST, or aspartate transaminase. This enzyme is found in several tissues, but it reaches its highest levels in cases of hepatitis. Next is ALT, or alanine transaminase. Like AST, ALT also rises to its highest levels in hepatitis. However, ALT is considered more liver-specific, which means it is a stronger indicator of liver damage compared to AST. Moving on to LD, or lactate dehydrogenase. Unlike ALT, LD is not specific to the liver. It is present in many tissues, including the heart and skeletal muscle. Because of this, LD is less useful when trying to pinpoint liver disease specifically. ALP, or alkaline phosphatase, tells a different story. Its highest elevations are seen in biliary obstruction, which happens when bile flow is blocked, for example by gallstones or tumors. ALP may also be slightly elevated in hepatitis, but its hallmark is obstruction of the bile ducts. Another marker is 5' nucleotidase, or 5'-NT. This enzyme is also associated with biliary obstruction and, when elevated, it strongly points toward that condition. Finally, we have GGT, or gamma-glutamyl transferase. GGT is considered very liver-specific. It shows the highest increases in cases of biliary obstruction and is also well known to rise after alcohol ingestion. Elevated liver enzymes can be remembered with a simple mnemonic: A, B, C. A is for alcoholism. Chronic alcohol intake damages the liver cells, leading to elevated liver enzymes. This is one of the most common causes of abnormal results. B is for biliary obstruction. When bile ducts are blocked, either by gallstones or tumors, liver enzymes rise. This is a key clue for obstructive liver disease. C is for cirrhosis. Cirrhosis is advanced scarring of the liver from chronic injury. It results in abnormal structure and function of the liver and causes elevated enzymes. So remember, alcoholism, biliary obstruction, and cirrhosis. The ABCs of elevated liver enzymes. When evaluating liver disease, it is important to distinguish between hepatitis and biliary obstruction. In hepatitis obstruction, the liver is inflamed and damaged. The hallmark findings are elevated AST and ALT levels. These enzymes rise significantly in hepatitis. There may also be a moderate increase in GGT and bilirubin, but only mild or no increase in ALP and 5' nucleotidase. In contrast, biliary obstruction happens where bile flow is blocked. The key markers here are elevated alkaline phosphatase and 5' nucleotidase. Both GGT and bilirubin are also increased. AST and ALT may rise slightly, but not as prominently as in hepatitis. To summarize, in hepatitis, the highest elevations are seen in AST and ALT, while in obstruction, the highest elevations are seen in ALP, 5' nucleotidase, GGT, and bilirubin. This comparison makes it easier to differentiate between hepatitis and biliary obstruction when looking at liver enzyme test results. In muscle disorders, common conditions include Duchenne's muscular dystrophy, trauma, surgery, intramuscular injections, and infections like trichinosis. Specific enzyme markers are elevated. The key markers are creatine kinase, also known as CK, aspartate transaminase, or AST, and aldolase. These enzymes reflect muscle injury and breakdown. In acute pancreatitis, both amylase and lipase levels rise. Amylase increases in both the blood and urine, but it stays elevated longer in the urine. Lipase is more specific for pancreatitis than amylase and remains elevated for a longer duration, making it the preferred enzyme for diagnosis.